It is my pleasure to host today for this after session Professor Vitali. Professor Vitali is working at the University of Bologna in Italy. He's a very well-known investigator in the field of hepatocellular carcinoma, contributing important publications over the years. And I would like to highlight a recent one entitled Merits and Boundaries of the BCLC Staging and Treatment Algorithm, Learning from the Past to Improve the Future with a Novel Proposal. So Dr. Vitali, first, congratulations to you and your co-author for this excellent paper. And I would like to ask you, what are the boundaries of the BCLC system?
Okay, the BCLC is simultaneously a staging system and a treatment algorithm. As a staging system, it works quite well, so there is no problem. The problem are in the treatment algorithm, because this treatment algorithm is based on the philosophy of stage hierarchy, which means that is the stage that dictates treatment choice. So we have only one choice, one treatment choice for each stage or substage. So the main problems are two. The first problem is the risk of non-adherence to the algorithm. We have many publications showing that in real life, the adherence is lower than 50%. But the main problem is the risk of under-treatment of the patient, because the single treatment allowed from the scheme is often not the best treatment for the patient.
So to address this point, you propose two new concepts, which is the multiparametric therapeutic hierarchy and the converse therapeutic hierarchy. Can you explain?
So this concept is based on two sub-concepts. The first sub-concept is represented in the vertical axis of our proposal, is the concept of ordinal therapeutic hierarchy, which means that treatment choice is independent from tumor stage, and treatment choice has a clear hierarchical order from liver transplantation to liver resection, ablation, intra-arterial therapies, and systemic therapies. But along this system, the risk to have an over-treatment of the patient. So it's important to have also the horizontal axis, which is the multiparametric expert decision parameter. That is a sort of a checklist with all the variables fundamental for treatment choice, from patient fitness to all tumor characteristics, also biomarkers, PET scan, all the characteristics important for treatment choice. Liver function, not only child PUG, but also ALBI score, evaluation of liver volume remnant, and other parameters. And the last parameter, very important, is the feasibility of the treatment, which depends from resources, costs, local availability. So all these parameters are important to avoid over-treatment and under-treatment of each patient.
Yes, I really enjoy reading the paper. Basically, what I think you did is really you turn the BCLC system from 90 degrees, and you put the treatment on the vertical axis, and you go down in the hierarchy.
Yes.
And you expand the horizontal, taking into account different parameters, multiparametrics with frailty, for example, and things like that. And you also have the converse hierarchy. Can you just say a few words about the converse part?
This is probably the best interesting part, because although we represented this with a dashed arrow, because the evidence is not very strong about this argument, but this concept is very revolutionary, because now we have many novel systemic therapy with, such as immunotherapy, with a great ability to reach objective response rate. So the concept of converse therapeutic hierarchy is like an umbrella concept, including both conventional conversion, which means the possibility to make possible in a patient suitable for radical therapy to achieve the radical therapy, but also increase the effectiveness of radical therapies. So we in patients who are already suitable for radical therapies, neoadjuvant or adjuvant therapies may increase the effectiveness of these therapies. So this is an umbrella concept, very important, and we hope we will have more evidence about this important field.
How do you think this new proposal will actually impact the field?
It's interesting that in the last press in Journal Hepatology, you will see two letters now, one from the BCLC authors criticizing our paper. They say that our proposal is not evidence-based. Why we make a response letter to this with the help of an expert methodologist from Italy, and we show that probably our proposal is more evidence-based if we use the GRADE method than the BCLC one, because we are much inclusive of all the literature evidence available. So probably the first impact is probably we propose a methodological new way to describe the proposal to help patients with SCC, which is more evidence-based than the BCLC scheme. But the most important impact is that we propose a patient-centered proposal and not a stage-centered proposal. And then with this proposal, we think to do the best for each patient, for the individual patients. So the main advantage is clinical more than scientific.
Well, thank you very much for sharing your thoughts and for participating at this Ask the Author session.
Thank you very much.
Be part of the future and join our fight against liver cancer.